Hi, thank you for joining tonight. I hope you guys find this lecture educational. I'm going to be talking about common causes of back pain and some treatment options that are available. This is just a little guideline so you can see exactly what we'll be discussing tonight. So just to start off with some epidemiologic data, throughout a person's life or throughout the US, approximately 84% of adults at some point will have low back pain, which is a pretty significant amount. When we look at primary care doctors' offices or any other physician's office visits, about 1.3% of them are related to back pain itself, that these people are going in, or patients are going in to having evaluation for. Looking at the prevalence of back pain or any pain overall, just chronic pain, approximately 50 million people suffer from chronic pain overall on a daily basis. About 20 million or 19.6 million people suffer from high impact chronic pain. And what is high impact chronic pain? This is pain which really prevents you from working, interacting socially, doing any self-care activities for at least 6 months or longer. That's 8% of the population that we see are impacted by chronic pain in this category. Now, when we look at some other diagnoses out there, such as diabetes, about 10.5% of the population have diabetes. Coronary artery disease, about 6.7% of the population, or 18.2 million. And then cancer is even less than that, fortunately, but there are about 16.9 million people in the US with cancer. So when you look at these numbers overall, about 28% of the population is impacted by chronic pain. 10% with diabetes, 6.7% with coronary artery disease or heart disease, and then about 6%, 5 to 6% with cancer. So what are the risk factors for chronic pain? Smoking, unfortunately, is one of the big risk factors. If you're a daily or chronic smoker, that can unfortunately make the pain more prevalent and also worsen. Obesity, age, as we get older, we develop more and more arthritic changes that can also impact or cause pain. Being female, interestingly, there's a higher risk of chronic pain in that category compared to being a male. Strenuous work and sedentary work. People who are doing strenuous work, like construction workers or those who are doing labor jobs, and there may be an injury or there may be something that happened that can cause pain over time or increased formation of arthritic changes. Low level of education, that can also, unfortunately, leads to chronic pain. Being on workers' compensation, job dissatisfaction are also contributors. Then we look at psychiatric disorders. Now, with psychiatric disorders, many times there are underlying issues with arthritic changes, but this can actually amplify the pain. Anxiety, depression are two of the main things and we'll touch on this a little bit later as well. But there can also be something called somatization disorder, and what this means is that a person has very extreme focus on their painful symptoms, and this leads to emotional distress and functional problems, and that can also amplify the pain. So how much does this cost our society? Now, there's a study that was done back in 2010, and so we're looking at $2010, meaning the value of dollars back in 2010. It cost the U.S. economy approximately $560 billion that year because of chronic pain. And this is not even worldwide, this is just the U.S. This figure comes from the cost of medical care related to pain. It comes from economic costs, meaning patients are on disability. How much are we actually paying for their disability? So that's also factored in. And also for people who are not able to go to work, the lost wages and productivity that we see. So that all factors into about $560 billion. And now in today's economy, where the dollar's worth a lot more, this figure is likely a lot higher. So a lot of people have not seen what the actual spine looks like. So I wanted to go through a little bit of anatomy as well. When we all see what the back looks like. You can see the skin, you can see the buttocks area, you can see part of the ribs and well, not ribs, but where the ribs will be located. So we're gonna go a little bit deeper, and we're gonna start with the skeletal anatomy. Now this is what the spine looks like along with the pelvis. We're looking at the deepest structures. The spine is actually made up of multiple bones. They're called vertebral bodies. There is just one big bone. There's the front part, and then there's a back segment, where there's some joints that are located. There's a small little joint on either side of the spine. Now, if we look a little bit lower down, you have a big bone, part of your spine called your sacrum, and then it attaches to your tailbone. This sacrum attaches to your pelvis. That's the big structure that's outside. And that attaches to your hips. So this is the bony anatomy of the actual spine itself. And then you have, of course, your ribs and everything that are higher up. Now, in the next slide, I'm going to add a few, in the next subsequent slides, I'm going to add a few different structures on so you guys can see what it looks like. So in this one, now we have ligaments. Now, ligaments are a type of tissue which are tight and they hold the bones together. They're really there to help support us so we can stand up straight and keep that stability there. So we're going to take these ligaments away now and add the nervous system. Now this is a complex web where you can see these yellow lines, those are the nerves. They're going out of the spine and they're going to the abdomen, they're going to the ribs, they're going down the legs. You can see the big, thick, yellow-colored nerves that are going down. That's your sciatic nerve coming out from the back. And that's typically going down into your legs, your thigh, your legs, your foot, that area. So you can see the nervous system is actually very complex. Now, from the nervous system, we're going to go to the vascular system. And the vascular system traditionally follows the nervous system along. So you can see the red lines and the blue lines. The red lines are the arteries, and they're the ones that are supplying nutrition to all the structures that the muscles, the joints, everywhere that these blood vessels go to. The blue lines are blood vessels that are taking the blood back to the heart. The red ones are the ones that are bringing the blood from the heart and the lungs to the rest of the body. You see a lot up front near the abdominal area because that's where all our abdominal organs are. And that's why it looks more of a web up there, but there's a lot that goes into the back as well. So the next layer we're going to talk about is the musculature. Now there's different layers of muscles, and we're going to keep adding more and more on as I go. There are deep muscles that help support the spine. The muscle's responsibility is actually to help you move from side to side, forward, backwards, in different positions, so you're able to get around and do what you want to do. So this is the first layer. You can see the deeper structures. They're attached directly to the spine on the bones. And we're going to add the next layer on. Now these are some of your paraspinal muscles, so these help support your spine as well. We're going to add another layer on. And now these layers are, as you can see, we're building upon muscle layer after muscle layer. And these all have individual responsibilities from different positions. Some are actually even helping you out with your movement of your shoulders as well, depending on which muscle we're looking at. But most of these focus on your spine, your back, your pelvis, that region. So this big muscle, the one that's attached, is actually one that attaches to your shoulder, so it can help you do like a pull-up as well. But they also have responsibility again in your low back. We're also seeing some of the muscles that are in your buttocks area now. And then we get to even more superficial layers, and you can see your glutes on the outside. The reddish maroon color is the actual muscle. The whitish color that the muscle is attached to is the actual tendon. The tendon typically doesn't move. It attaches to the bone and the muscle, but it's the muscle that really contracts and pulls on it so you can do any sort of movement. So let's get to the main topic that we wanted to talk tonight about. What causes back pain? Now we said about 1.3% of primary care office visits or any physician visits are due to pain. So when someone is seen by a primary care doctor's office or primary care physician for back pain, approximately 85% of them really don't have a known cause for it. We just don't have an answer why the back pain happened. Typically, we rule it out to just being something more musculoskeletal, meaning muscle-related, or maybe something bony or tendinous or ligamentous structure is causing it. For most of these patients, it'll improve after just a few weeks. Now, there are some other more serious causes, and I'm going to mention some of these, but this is not going to be the focus of tonight's discussion. But some of the more serious causes that we want to rule out are if there's a fracture. Most of the times we see a fracture if there's any sort of injury. It could be like a compression fracture because someone has osteoporosis, and that may happen just incidentally, meaning it just happened on its own, or it could be from a car accident or fall. Anything can, there's a number of reasons why a fracture can happen. Infection, cancer, or some other more serious things that we want to make sure we're not missing. Typically, someone who has an infection, there's usually a source for it, especially if it went to the spine, whether they've had back surgery caused the infection, or it could be related to such an IV drug abuser. IV drug abusers, they're injecting themselves, they're putting themselves at risk of infection, not just in the spine, but other areas as well. Or it could be from the bladder or somewhere else where it can spread to the spine. But we usually see other symptoms when there's an infection there. Cancer, same thing. We'll look for different signs such as unintentional weight loss, fever, chills, night sweats. Things like that are clues for us that we need to look a little more into why they're having these types of symptoms and why they're having concurrent back pain. Some less serious causes, and to patients it may not feel less serious, but these are not. These are things that may not need urgent attention. But compression fractures, one we talked about just a moment ago, we do treat that as fast as possible because it can lead to more disability, and we don't want that. A nerve compression causing shooting pain, and I'm going to talk a little more about that in one of the next slides, and musculoskeletal issues. Additional causes are arthritis. Typically, whenever we're treating back pain, most people do have arthritic change, especially our older population. Our younger population may not be related to that, but it can be still. Scoliosis is another cause of back pain. Severe scoliosis is something that I don't see too often in my clinic, but we do see it every now and then. Usually when there's mild scoliosis, we just treat that conservatively with some therapy, but it's usually not a big concern when it comes to back pain. Scoliosis typically can cause more tension on the muscles, and that can cause the pain, but it's not always the cause or always the case. Rheumatologic disorders are another place where we can have back pain. Some of the examples are lupus, rheumatoid arthritis, or even ankylosing spondylitis. These are diagnoses that if someone comes in that has a rheumatologic disorder, I would suggest getting a rheumatologic evaluation. There are things that we can do to treat this pain, but trying to treat the underlying cause oftentimes is a lot more successful if there is something rheumatologic going on. Psychological disorders, we did talk about anxiety, depression. With patients who have these types of issues, oftentimes they do have underlying causes, but the depression and anxiety can really amplify the pain, and so we really want to get that treated as well. And then there could be other non-spine causes. Sometimes an OB-GYN issue, such as endometriosis can cause back pain. Doesn't mean it will. Hip joint pain is another source where we see back pain come from. So I've had patients come in who've had kidney stones. Fortunately, they've resolved, but they suspect that maybe it could be coming from that. So there could be other reasons as well, is what I'm trying to get at. It may not be all spine related. So this is a particular diagnosis we see often in a clinic, myofascial pain. And what does myofascia really mean? It's basically muscle pain, and the tissue that is on top of the muscle called the fascia. It just surrounds the muscle. That can actually be tender or can be painful. Oftentimes stretching the muscle can be painful in this situation. Many times people have knots as well. And when you push on that knot, it just causes pain that radiates out. That can be a tender or trigger point where it's originating from. The causes of this are usually poor posture. Nutrition can also unfortunately affect it. If you're not really exercising or not moving around, you're not sleeping well at night, just the stress from all this can increase the pain and cause this type of myofascial or muscle soft tissue type pain. Again, we're coming back to the psychiatric side of it, which is the depression, anxiety can really amplify it. Obesity is another source. Smoking, hormonal changes, these can always make the pain worse or even bring it on. We typically treat this with medications and physical therapy. Medications include muscle relaxers and anti-inflammatories are the primary treatment. We can also when we send you physical therapy, they may also do some dry needling, especially try to break up some of these knots. In the clinic, we do trigger point injections, and trigger point injections are basically putting a needle in the area where we see a knot, and we inject a little bit of numbing medication, and oftentimes we'll include some steroid as well. Steroid is not always necessary, but it does help for many of our patients. Even massage therapy can make a difference, just some myofascial release techniques. So. So a radiculitis or radiculopathy, and what this means is basically pain that originates from the spine that radiates down the leg, the thigh into the leg or the foot, depending on how far it's going, which nerves is involving. A lot of people like to describe this as sciatica. Sciatica is just another terminology, another word for radiating pain. And radiating pain can happen for a number of different reasons, and we're going to talk about this one first, but there's another slide that I'll show you that also has radiating pain for a different reason. So the first one is a disc herniation. Now the picture that came up on the left shows a disc with a pink inner gelatinous structure. It's just like gel or liquid, a thick liquid, and it's surrounded by a thick structure that helps hold it in. Now when there's a tear in that structure, as you see on the right side, or that inner part just starts leaking out, and that's when you get a herniation, a disc herniation. And that could put pressure along the nerve root, and that nerve root, if it gets irritated, it'll cause the pain to go down the leg. This gelatinous or this gel-like structure can also release inflammatory chemicals, unfortunately, that can act as an irritant and cause the pain to go down the leg as well. Cause the nerve to get irritated and cause the pain to go down the leg. So, a second source would be a cyst. Now we looked at some of the joints in the spine when we looked at the bony anatomy. They were on both sides. So when you look at a cyst, it can go in one of two directions. It can go out of the spine. In that situation, it typically doesn't cause pain or discomfort to patients. However, if it goes in the spine, as you see on this picture right here on the right side, it can definitely cause compression along the nerve root or the spinal cord. It can cause irritation, inflammatory changes, and the pain can shoot down the leg as well. Another source would be something called spondylolisthesis. And now this is just a fancy word for the spine that should be aligned nicely, but it shifts. And that's what we're seeing in this picture. And it's just different levels of it. The first picture on the left is a normal spine. It's aligned well. The second and third picture show a certain degree of slippage of the bone. And the bottom ones are actually even more. It's just different grading systems. When we get to the bottom two pictures, at that point we do see a lot of instability, and it becomes more surgical in terms of treating it. But the top two, if there's no neurologic changes, oftentimes you are able to manage it conservatively, unless there is some sort of mobility in the joint, then a surgeon would definitely have to get involved. Now, typically when we see a spine like this, there's compression of the nerve root where the nerve is exiting out of the spine. It's not so much in the middle where the spinal cord is going through, it's where the nerve exits out of the spine, and that's the red area that you're seeing. Spinal stenosis. Now, what does stenosis mean? I'm sure if you've ever seen a primary care physician or a pain physician or spine surgeon, that word has been thrown out there. Stenosis just means narrowing. And when we look at the spine, on the picture that's on the screen, the left side of the spine shows a normal or healthy spine. No evidence of any sort of arthritic changes in the joints. The disc is not herniated out. The yellow structure in the middle with the dots in, that's the nerve, the spinal cord with the nerves that are going through it. That's a healthy, normal spine. Now, when you look at the one on the right, all of a sudden you see that red area, which is the joints. Those are arthritic changes growing into the spine, so it's causing narrowing. You have structures adjacent to it called ligaments that we saw earlier, and those ligaments can get enlarged, unfortunately, and that's a sign of arthritis as well. And that, when it gets enlarged, starts putting more pressure within the spine. And then all of a sudden you may have a disc herniation that comes in from the front and works its way into the spine. And so that canal that was nice and open, that is now narrow. And if you look at the picture on the left, you see those nerves, that bundle of nerves, and on the right, you really don't see much of that. This is pretty severe compression along the spinal cord. Now, that doesn't mean you'll be paralyzed from it. Oftentimes this happens at a gradual pace. And so if it happens, our bodies are able to really adapt to it, but it can definitely cause pain or disability. And when that comes on, we want to treat it, and there are options to treat this. A fifth possibility is scar tissue. Now, I typically see scar tissue develop after spine surgery, but it's not common. It's a very small percentage of patients that we actually see scar tissue develop after surgery. When it does happen, though, it can surround the nerves, and that can cause irritation, and it cause pain that shoots down into the legs as well. But we'll talk more about different treatment options for these in some of the future slides as well. Typical symptoms, again, for these types of pathology is back pain and shooting to the lower limbs, or the sciatic symptom. We usually have to get a really good history. We'll do an examination as well. And for many of our patients, we will get some imaging, most of the times an MRI or CAT scan, to help diagnose this more effectively. So the next diagnosis is lumbar facet pain. And what this means is that we talked about some of the small joints in the back. There's one on either side. These joints, as they become arthritic, can cause back pain. Most people have more severe back pain than leg pain, but there can be some referred or some sensation of pain that goes into the buttocks area, the thigh area, and on a very rare occasion have I seen go below the knees, but it can happen. Typically, it's really the back pain that's really back and buttocks area is what we're seeing affected by these joints. Bending backwards can cause the pain to get worse. Sometimes it could be from bending forward as well. People describe a stiffness. They hear a grinding or popping sound in the back. It's not the grinding and popping sound is not only from this. There can be other causes for it as well. But many patients will describe it that it's coming from that could be coming from these joints. In order to determine if it is the joints that are causing, we really do, again, an in-depth history with examination and again, obtain some imaging. We typically treat this conservatively as well, and we'll talk a little more about some of the conservative options later, but it's physical therapy, medications, and interventions. Sacroiliac joint pain. So this is the connection between the spine, which is from the sacral area we saw in the bony anatomy, and your pelvis. And patients can have pain that originates in the low back, in that sacral area. It can go to the groin as well, especially if there's some instability. It can also radiate down into the back of the thigh and the calf. Typically, when it starts radiating down, it can actually get less and less intense. The back is the worst part of it. It doesn't always go to the groin, but it does. It is possible that it can go there. Causes of this are just, something happened, something triggered it, causing inflammation in that area. It could be related to arthritic changes. Rheumatologic diseases like ankylosing spondylitis or gout can also cause it. Obesity, there's a number of causes for it. That joint is really holding up our entire torso, head, neck, arms. It's holding up a lot of weight. Symptoms for this are, as you can see, is again, back, buttocks, and hip pain. You can some people describe it as stiffness, sometimes some burning or numbness sensation can also present with it. And again, as always, we do a good history exam and physical on this, along with getting some imaging to see if there's something else that's going on or rule out other causes. And we treat this conservatively, start with usually therapy, medications, and then we can get into interventions and surgical side of it as well. Compression fractures. This is typically related to osteoporosis or to cancer. That's usually the most common population we see it. The osteoporotic fractures are usually the most common, followed by cancer. And then it can also be related to injury, injuries such as car accidents or falls. Someone who has an osteoporotic fracture may not even have fallen or injured themselves. Just coughing or sneezing can cause a fracture like that in the spine. Usually we see this in someone who's older, 60s, 70s, 80s, even and older than that. There are approximately 750,000 fractures a year, or affects about 750,000 people a year because of these fractures. We diagnose this by history and physical as well. We're looking for tenderness along the spine, right in the middle, right where the fracture site would be located. X-ray would be one of the key things to get in our patients initially to see if there is a fracture there. Most of the times these fracture, when a patient presents, it's just sudden onset of back pain. They have trouble walking, doing any sort of activity. Many patients end up with a walker or a wheelchair just to get around. They have a tough time getting out of bed or going to the restroom. The only thing that really helps is just relaxing, not doing anything. And so if the pain is not that bad, then we'll treat it with medications, some therapy and bracing. If it is worse, and it's really causing that disability where you really can't get around or do anything, then we're starting to look at interventions, particularly putting cement in the bone to help solidify the fracture so it's not moving around anymore, but and improve the pain as well. And we'll look at a kyphoplasty in one of the future slides. So here's a big question I get asked. When should I get imaging? When someone comes to my clinic, if it's something recent onset, they're young, I typically will get an X-ray just to make sure I'm not missing something, but it's not absolutely necessary. We can, if it's just like a muscle sprain, most people will heal just in a few weeks. Now, if it's depending on their age, what they're presenting with, an X-ray is definitely indicated. If there's nothing concerning on the X-ray, then we'll do a conservative approach to treating the back pain, usually some physical therapy, medications. If that improves it, then we don't need any other further advanced imaging. Now, if that conservative approach does not work, then at that point, we are looking at getting a CAT scan or an MRI to further evaluate what is going on in the spine and why this pain is still persistent. Many times we do get an answer from looking at this imaging. There are times where even with that we just don't have the best answer on why the pain is still persisting. So when is the right time to get an MRI or CAT scan? Usually if you fail a conservative approach, or if we're thinking of a compression fracture or anything, then we'll probably opt to get an MRI or CAT scan a lot sooner, or maybe another study. So here's from here we'll talk about some of the treatment options. Physical therapy, medications, interventions. We'll even touch on medical marijuana as an option. So physical therapy. I always feel exercise, core conditioning are one of the key components to healing. If you can really stabilize your spine, work on improving it, you can reduce your back pain, you can improve your functionality, you can prevent future flares as well. It's actually a great way that's not interventional, that's not going to cause, that you don't have to worry about medication side effects, things like that, in trying to improve the pain. Going through physical therapy is very important because you can get help from a person who's trained in teaching the proper exercise. They can also do different modalities to help you out reduce pain. Myofascial release techniques, they use ultrasound, they may use e-stim, or various different things to actually help you. Types of exercises that we use, or the therapists use, are stretching. It improves and helps maintain range of motion. They may do some dynamic exercises as well that works on balance and stabilization. It helps strengthen some of the secondary muscles, and then they work on core strengthening as well. And so there's different exercises for that. They'll work on the abdominal, low back, and pelvic muscles. So medications, there's different categories of medications out there. There's anti-inflammatories, muscle relaxers, nerve stabilizers, and then we get into opioids. The street name for opioids are narcotics, but the medical term is typically opioids. So anti-inflammatories and muscle relaxers are usually the first line. We want to try the non-addictive stuff or out there first to see if that improves the pain. There are some risks with these category of medications, especially if you have kidney disease, liver disease, heart problems, muscle relaxers. So these are things that you definitely want to let your physician know if you have any of these issues, even stomach issues. That'll help determine which direction to go with their medications. Nerve stabilizers is another category. If someone has pain that's shooting down the leg, especially if it's been going on for several months, we'll give a nerve stabilizer a try. And we usually start off at a low dose and we'll gradually optimize it to their tolerance. Opioids are another option we do use to treat pain. Unfortunately, with opioids, it's not really treating the underlying problem. It's really trying to mask it by blocking the pain receptors in the brain. And there are risks of addiction, dependence, and tolerance of these. I don't know if anyone knows what's the difference between them, but addiction is when someone's is not really treating their pain anymore, but they're really trying to get a high off of it. They're using it inappropriately. They're not taking it as it was prescribed. They're really trying to get it from friends, family, and it's basically trying to just do inappropriate things that will give them that high. Dependence is when your body feels like it needs to stay on that medication. You try to come off of it, you go through withdrawal symptoms, or your body's telling you in one way or another, saying, hey, I need to stay on this medication for me to function. It may not be withdrawal symptoms, it may be something else could happen as well. And the tolerance is when you're taking the same dose of medication for a while, and all of a sudden, the medication may not be as effective, and you need to go up at a higher dose. Typically, when someone develops tolerance, we don't want to always just go up on the dose, but we may want to do something called an opioid rotation. Opioid rotation is when we go from one medication, an opioid, to another, and oftentimes that works well, and we'll go back to the original, and it's more effective. Or doing an opioid holiday, where we will gradually taper you off the opioid, take a break for a few weeks, maybe a month or two, and then go back on it, and oftentimes it's a lot more effective. People get scared of opioid holidays because now you're going to be off your pain medication. However, we usually try to treat you with other ways during that time as well when taking those opioid holidays. Doesn't mean that's the right option for everyone. Again, we have to do a good evaluation and see what's best for each person. So let's get to the procedures. Epidurals. Now, a lot of people have heard about epidurals, labor epidurals, pain epidurals. For pain epidurals, we're typically injecting a medication called a steroid or cortisone. The epidural is the name of the procedure is because that's where the needle goes, it's that space that we enter into. And the medication we're injecting is the actual steroid or cortisone. And there's different types or names of steroids or cortisones out there. Typically, once we get the needle into the spine, we're going to put a little bit of contrast in. And when you put the contrast in, as you see in the right picture, we want to see it going around the nerve root, but going into the epidural space. Once we see that happen, then we'll inject the medication. And the goal of this is to help reduce inflammation and the pain generators in that area. Typically, we'll target a particular area of the spine based on what the patient's symptoms present with. However, if it's not as effective, we'll either look at a different location as another source for it, or try alternate options. I'm going to do that picture one more time so you can see what it looks like. So this is what the spine looks like with the needle in there, and this is with the contrast in it. You can see the spread of the contrast. It's going all the way up and down and along the nerve root. A radiofrequency ablation. So this is where we cauterize the nerves that go to the joints. Typically, when we do this type of procedure, we're not going straight to doing an ablation. We'll do a test dose first where I'll go in and I'll numb the nerves. If the numbing works for a few hours, then I will then I'll repeat it one more time for confirmation. If it helps again for a few hours, and the patients feel that they've got good relief from it, then I'll go in and I'll actually cauterize the nerve. So unfortunately, it's a stepwise process, and we don't want to go in and just cauterize someone's nerves because without testing it out, it just would not be effective. So an alternate option of this is actually putting some steroid into the joints. I don't have a picture of this up here, but we could go into the facet joints, which is the small little joints I talked about, put some steroid in there. Now, typically we do that if the pain is recent onset or acute. Acute meaning some recent onset. That seems to work well, but if this is someone who has chronic or long history of back pain, the ablation has been shown to be more effective. Again, this is not for everyone. We'd have to do a full evaluation before we can actually consider this as an option. I'm going to go to the next picture, and you can see a side view of it, and that's the nerve being burned from the needle, the tip of the needle. There's no surgery involved. It's just a needle that goes to that area, and it's done through X-ray guidance. This is just a side view of the same thing, so you can see what it looks like when I on the pictures that I seen instead of the cartoon version. SI joint. So we talked about SI joint pain earlier. SI joint pain can be treated, like I said, with conservative measures, with physical therapy and medications. If it's severe enough, and if we are able to isolate to that region, then oftentimes we'll put a needle into the joint. It goes actually into the bottom of the joint, and then once we put a little bit of contrast in, we'll see the contrast flow through the joint, and I'll inject the medication. I'm going to show that picture on the right again. And so this is the picture without the contrast, and then when I put the contrast in, you can see it's flowing all the way through the joint. So this next topic, I'm going to actually show you guys a video. It's actually something called a spinal cord stimulator. So this is a little bit more advanced. I like to describe this almost like a pacemaker. A pacemaker goes into the heart with its leads, and there's a battery that actually stimulates the heart muscle whenever it needs to. With a spinal cord stimulator, and we'll let the video go in just a moment, but it's a device that we put along the spinal cord, and it helps put a current along that area to help modulate or help control the pain signal that goes to the brain. So we'll talk a little more as soon as the video is done. I believe that was the end of the video, and go to the next slide. So with the spinal cord stimulator, as you saw in the video, it's basically a lead that goes into the epidural space. The epidural space is a very thin space. That's where we do the epidural injections in and put cortisone in. We don't want to go inside the spinal cord. We want to put it on the outside of the spinal cord, but we enter in from your low back and go in and put the lead into the middle of your back. And it's from the middle of your back that we actually try to block the pain symptoms. Typically, most of our patients who've gone through this have failed a conservative approach with physical therapy. They've gone through medications. They've done a number of other injections with epidurals, ablations, or SI joints, depending on what their pathology is. So if nothing's really working, then and including surgery, many of these patients have also gone through the surgical side, and that also has not improved the pain, then we'll approach them with this as an option. It's not for everyone, and it's not 100% successful, but the nice thing is that we actually put you through a trial. And what the trial means is that we put the device in non-surgically, just into the spine, and the batteries on the outside, as the video showed, and we send you home and let you keep it in there for about a week and see how you do with it. Does it help with your pain? If it helps and actually improves your pain, not to the point where you have no pain at all, but it improves your pain so you have better quality of life, you're able to function better, get around, spend more time with your family, or just do whatever you want to do, then that would be an indication that maybe you want to do is put this in for a long term. But if it doesn't work for you at all, then this is something that we don't want to even approach. The surgical side of it is, if the trial works, then we got to actually implant this device inside. The implant is doing the exact same thing, except this time I got to secure the leads underneath the skin so that they don't move. There's still a risk of a chance that they could move, but we try to reduce that by securing the leads underneath the skin. And then I also got to make a little pocket for the battery and tunnel the leads over there. So it's minimally invasive. It doesn't require myself or my colleagues for us to go all the way down into the spine, like major spine surgery and opening you up and doing that. But it does require a procedure to actually put the leads in. So there usually is 2 or 3 incisions, depending on the person who's implanting it and how they're doing it. There's usually 1 or 2 incisions just for getting the leads in, and another incision for the battery. And this is done as an outpatient surgery, either at a hospital or a surgery center. A kyphoplasty. Now, this is when we do the compression when we see a compression fracture. A compression fracture is when we talked about when someone has collapse of the bone itself, either due to osteoporosis or could be from an injury. Typically, with a kyphoplasty, it's done as an outpatient procedure. We do this actually in my spine center, which is a clinic-based setting, but it can also be done at a surgery center or a hospital. We're basically anesthetizing the skin. After that, we're putting a needle, or a pretty larger needle, which is called a trocar, going all the way down to the spine. We'll then usually hammer that needle in through the bone into the spine itself. You do get sedation for this procedure because we want you comfortable during the procedure itself. Once we get the needle in, we'll put a little drill in. Sorry, I have to go to the next slide. We'll put a little drill in to make sure that the space is nice and open right into the fracture site. Once that drill goes in and opens the space up, then we'll put a balloon in to try to open the space up, but also try to get that bony structure back to looking normal. It doesn't mean it will get exactly back to normal, but we really try to open that space up. Once we open that space up with the balloon, then we'll take the balloon out and inject the cement. And once the cement is in there, we'll pull everything out and we'll be done. So this is the last topic I was going to talk about, was marijuana, chronic pain. Now, in Arizona, recreational marijuana has been approved. Now, there are some differences with which a lot of people may not understand. There's hemp, there's CBD, and then there's the THC side, or the marijuana side. Hemp is a type of cannabis. It's anything that contains less than 0.3% of the marijuana compound, the tetrahydrocannabinol, is considered hemp. So you can actually get hemp and CBD pretty much everywhere now in the U.S. It's been legalized. You don't need a card for it. You don't need any special permission to get this. And CBD is basically just an extract of that hemp itself. THC, there are some states that have approved it, some that have not. It's recreational or medical, and there are medical purposes that is approved, but it's basically anything that contains more than 0.3% of that THC. So this is just a graph, or not graph, but a statewide, you can see who has approved and who has not. The dark green is where everything's approved, meaning recreationally and for medical purposes. And as you get to the lighter green, it's where it's only approved medically, or they're basically it's not criminalized anymore. And the white or grayish area are the ones where it's still illegal. The federal government still considers medical marijuana illegal and has categorized as level 1, though, just to be aware. So in relation to chronic pain, typically if you can't treat post-surgical pain or a fracture or something like that with medical marijuana or any marijuana products, we find that it really just doesn't work. So if the pain is severe enough, it really won't help as much as what we've seen. However, it has been shown to be effective in chronic pain, especially in our older population. It's safer than opioids. You can't really overdose on it. You can get a euphoria or a effect where it affects your cognition if you take too much of it, but it's not going to cause an overdose. Like, it's not going to cause you to stop breathing or anything like that. Some of the literature has shown that it's less addictive. However, that it doesn't mean that it's not. You can still get addicted to marijuana, but it's less likely. So CBD tends to be much better tolerated even at larger dosages. Again, that's because there's less marijuana in it, or that THC that we talked about. However, if you take too much of it, then you could get that euphoria effect. The euphoria, what I was talking about, was that happiness, the joy, the excitement that you get. That it's just overwhelming, that feeling. And a lot of us typically don't want to have that type of excitement. It can make you just not feel yourself anymore. But again, CBD is less likely to do it. It is possible. THC is more likely to have those types of symptoms. There are some side effects that THC can bring, particularly in the short term. It can increase your heart rate. You can have some coordination problems, dry mouth, redness. It can reduce your reaction time. You can have some memory loss. These are just some side effects. So what are their uses? So CBD typically has been used for chronic pain, inflammation, migraines, nausea, seizures and epilepsy, anxiety, depression, psychosis, and mental disorders. THC is used for chronic pain, muscle spasms, nausea, insomnia, anxiety, low appetite. And this is not just fixed to this. I mean, there could be other uses for it as well. And again, like I said, it's not for everyone. So there still needs to be a lot of research that needs to be done in the CBD and the medical marijuana site. It's not something, even in our practice, we don't tell patients that, hey, you should go try medical marijuana. We usually want you to try other things and see if we can get your pain better. But if nothing's working, then it is something that we have suggested to some of our patients, as it has been beneficial. It's also been beneficial in getting some of our patients off opioids, as that's actually worked more effectively and reduced their risks. But you still got to take this product very carefully and be cautious about it. You don't want to drink alcohol with this. We really don't want to mix opiate with this as well. We want to try to avoid that if possible, because it can have that euphoric or cognitive issue. The other thing to keep in mind is that, unfortunately, it's not the best quality control when it comes to CBD and marijuana. When you buy, and I've heard this from a number of patients, where you buy a medical marijuana product one time from one company and you go back and buy the same product the same time from the same company, many times it's just not as effective, and they go buy it a third time and now it is. It's that quality control that's sometimes not always there. It doesn't mean that's with every company, and a lot of times it's really just trial and error. It's typically not covered through insurance. It's not, and a lot of people just have to pay cash for this. Again, with medical marijuana, a lot of this information I'm presenting likely will change as we learn more and more about it. This is something fairly new that we're getting into at this point. So when should you see your physician? This is a big question when it comes to back pain. Whenever pain starts to affect your ability to function, your quality of life, you really should consider seeing your primary care doctor or specialist, such as myself in pain management, or one of the other specialists that sees back pain out there. If you're having recurrent episodes of back pain, it comes on, a few weeks later it comes on again, months later comes on again. Those are types of things where you may want to come in and see if there's ways to prevent this from happening, or what the underlying cause may be. We won't always have an answer, but at least we may be able to treat it and do some preventive measures. Any back pain is persisting longer than 4 weeks duration. it's just not easing, it's not getting better, then you may want to consider an evaluation. If you fell, you injured your back, considering a fracture, or especially in our older population, it's just severe and disabling. Those are things that should bring you in a lot sooner, or at least get you to the emergency department or urgent care to be evaluated. Any neurologic changes, any weakness, numbness, tingling, particularly as progressing bowel or bladder changes, that's more of an urgent need to see a physician or go to the ER or urgent care. If you're having fever, chills, night sweats, or unintentional weight loss, then we're suspicious that is there something cancerous going on. You want to make sure you get that evaluated right away as well. It may not just be from back pain, it could be from something else. And above all, if you really don't know what's going on and you're questioning and you really need to see someone, be on the safer side and go see your physician, see your primary care doctor, or see a specialist like myself, and let's find out what is happening. So these are just some of my references, and I think we'll get to some questions. I like to describe a bulging disc is if you take a glass of water and you keep putting water into it, you see it starting to bulge out, but it hasn't broken through yet. It hasn't spilled over. That to me is more like a bulge. It's just sticking out. Maybe there's a little more pressure on the disc, but it hasn't herniated. Herniated is when now you have the structure is just broken through. You have the inner contents, that gel that we talked about, that's now herniating out or sticking out of the disc itself, that thick structure that we talked about in one of the previous pictures. That will, once that starts coming out, that's when you actually have a herniation. And there's different types of herniations as well, which I don't think we'll get into, but there's different ways to describe it, is how I'm saying it. It's a good question. Not an easy answer. There's a number of causes for that, unfortunately. We went through a number of diagnoses as well. If it's just localized to the back, it could be disc related. It could be joint related. It may be muscular as well. Sometimes just the bed alone could cause back pain. If there's an old mattress, if there's lumps in there, and it's just not conforming to your spine anymore as you got older, that can cause back pain. It's unfortunately there's not a good answer unless we evaluate that area. Oftentimes we'll have to get some imaging and see what's going on. It depends on the type of spine fracture also. If we're looking at a compression fracture, for many patients it will heal on its own. And if it heals on its own, the pain gets better, then yeah, we don't need to do anything further about it. But if you have someone that has a fracture in the spine, it's not getting better, it's left unhealed, meaning it still causes a functional decline. You're not able to get out of bed, you're not able to function, you're not able to get around, you're really struggling. Unfortunately, the risk of mortality means death, is actually pretty high when it comes to compression fractures like these. Now, if you're looking at a different type of fracture, which is going straight through the entire spine, meaning at a single level, or there's instability there, that's more concerning, because then that can lead to like a nerve, basically compromising the nervous system in that region. It can lead to paralysis, bowel bladder change. So those are things that you definitely want to get addressed by a spine surgeon if that's what's happening. If there's a compression fracture, then we definitely want to treat it so we can avoid later complications. Yes or no, it can go either way. It depends on your pain pattern. Now, if you have pain in your back alone and it's really not shooting down the legs, or maybe it's going to the buttocks, thigh area, and your exam shows that it is related to the joints, your imaging is also pointing us in that direction, then yes, I would say it's reasonable to go down the direction of ablation. But let's say your spine looks nice and healthy. I'm not seeing any arthritic changes in the joints. I'm not seeing, and you're not having that type of pain pattern, then it may not be the best option. We'd really have to evaluate you in clinic, see what the images look like, see what your pain pattern is to get a better idea if that's the direction to go in. So the most important thing is you want to get a history. We want to get a history. We want to find out exactly where the pain is. Once we figure that out, then we want to examine your back. When we examine your back, we're trying to localize, is it coming from the low back, or is it coming from the SI joint. Where are you feeling it? We're also typically asking questions like, are you walking bent forward? If you're walking bent forward and when you try to straighten up, the pain increases, starts going down the leg. It points us to a direction of stenosis as a possibility. It doesn't mean that that's absolutely true, but it points us in that direction. Whereas if you're having pain that's localized to the joint and you're able to walk around, but you're having pain there, but you're still able to bend forward and backwards, not really causing that much discomfort, maybe SI joint or it could be something else. Once we get that history and you've tried some conservative approaches, not getting better, then usually we'll get an MRI of the back. Now the MRI is going to be the key thing to diagnose whether you have stenosis or not, but we want to use that to correlate with your symptoms. Now I have patients in my clinic that have come in that have stenosis, but it's not always the source of their pain. So that's why that history and physical is very important. We really need to correlate the images the findings on the imaging with the pain symptoms and the exam very well. I actually wrote an article on this a few years ago. Degenerative disc disease is actually not a true disease. It's just been labeled as that. Degenerative disc disease, all it is arthritis or changes within the disc over time. You see some irregularities in the disc, and what I mean by irregularities is just like a wavering or compression down on the disc itself. Is dehydrated now, and that happens as we get older. It's just a natural aging process, but we call that degenerative disc. It's just a way of describing arthritic changes. Once you develop the spondylolisthesis, I haven't seen it reverse itself on its own. I do feel therapy, exercise, conditioning, working our core and strengthening it does work very well in preventing from progressing. But as long as there's no instability there, and what I mean by instability, as long as when you look at that area, as long as there's no additional movement in that area, then I'm not as concerned unless it's causing more symptoms, particularly those sciatica-like symptoms. So I do treat piriformis syndrome. We didn't talk about that much or at all. Piriformis syndrome is basically pain that looks very similar to a nerve irritation in the spine, a sciatica type symptom. It goes from the buttocks area and radiates down the leg. Typically we diagnose that again based on history and physical. During my physical examination, I'll actually stretch the piriformis muscle. And if that if that causes increased pain in that buttocks area, causing it to shoot down the leg, that's usually diagnostic that it is piriformis syndrome, but it doesn't rule out the spine, meaning a herniated disc causing it. So treatment for that is usually, again, physical therapy. I'm a big believer in exercise and conditioning. We can also do an injection into the muscle itself. Now the injection, I typically do that under fluoroscopy or X-ray guidance. And what that means is that I actually have a device that's taking pictures like the X-rays we saw with the epidurals and the ablation. And I'll guide the needle all the way down to the muscle. Now I can't see the muscle, but I usually will, there are landmarks that we use. I will outline the location where the muscle is and go in with the needle right into that area. And then I'll stimulate the muscle with a device to make sure I'm actually in the correct muscle. Patients will usually feel like a little twitching sensation. Once they feel that twitching sensation, and it's not painful, it's just something that you feel, and I'll be able to visualize it. I'll inject a little bit of contrast to make sure it goes in the direction of the piriformis muscle. If it doesn't, I'm going to redirect my needle. But I'll inject a little bit of contrast, and as long as it goes in the direction of the piriformis or into the piriformis, I'll inject the cortisone with some saline mixed together or numbing medication to help alleviate some of the spasms or pain in that area. Some of them we already went through for spinal stenosis, which was the epidural steroid injection. Unfortunately, it's not a fix where we're going to be able to correct the problem when it comes to stenosis, but it does help alleviate the pain. It doesn't work for every single patient. However, it does work for a number of our patients in helping them reduce it and get a better quality of life. Unfortunately, with epidurals is that if it works well, a few months down the line or maybe a year down the line or sometimes even longer, may have to repeat it. The other thing we use is that spinal cord stimulator. Spinal cord stimulators work very well for neuropathic or neurologic type pain. When I say neurologic, I mean nerve compression-like pain or disc-related pain. It's really there to help alleviate some of the symptoms. And then the therapy, the exercise, and medications are the other things that we use to treat that area. And there are some other options that are coming out, hopefully in the near future, and we are actively looking into meaning other ways to treat it, not just surgically but non-surgically. So hopefully, as we review the literature for stenosis and these other treatment options, we'll be able to bring those to Core as well, Core Institute. We'll probably have to do another presentation at that time. Typically, I talk to patients who've been through a number of different treatment options already. Because we always want to try to see if we can improve the pain through without putting you on any additional medications or without putting you on any sort of other substances if we can. The typical patient is someone who's tried therapy, tried the conservative route, may have tried injections as well, maybe even some medications. They may have seen a surgeon as well and really not a surgical candidate, or maybe had surgery. And nothing is really working for them. And at that point, I usually do bring up that option as, we can look at this route, see if it'll work for you. Is it for everyone? No. Unfortunately, there's no, we've tried medical marijuana on some of our patients, and some have done phenomenal with it, where we've gotten them off opioids. And some have not even been on opioids actually, and they've just been able to treat their pain. They have a better quality of life. They're able to get around. They're functioning better. They've gotten back to work, many people as well. And then we have another group of patients where unfortunately they tried it, and they tried various different types. And when I say types, I mean different products with medical marijuana, and it really hasn't helped them out. One thing I didn't talk about with medical marijuana is, people always think that you had to smoke it. These days, you're not just smoking marijuana. My patients who have actually tried it, I don't know anyone who's actually gone out and smoked it. They're all using like topicals, they're using oils, they're using edibles. They're using different ways, patches. There's some oils you can put under your tongue as well, or just rub on you. So there's different ways to actually use the medical marijuana side of it. And see if it actually improves your pain. And not one way is right for every patient. There may be something else that may work for you and something else that works for someone else. But always learning more about it is beneficial, seeing what worked for others.